erythematous papules around the neck. So it's a very short case, so I think this will be a very nice first aliquot.
All right. I can get us started. So chronic cough. So with chronic cough, I would say it's important about what company it keeps. Usually with chronic cough, the duration, and the other symptoms that patient is having. Most often, I think we think about something like GERD, something like a postnasal drip, something like asthma that can kind of present as chronic cough. That like kind of in the outpatient setting, those things tend to be the most common that we see, and a lot of the time we ended up doing like managing one and see how the patient does, in addition to like kind of working up and just like make sure there's no red flag symptoms. The red flag symptoms you want to look at is other signs of inflammation, prior infections, weight loss. So with chronic cough, I always like think about first what company keeps, making sure to go a good review of symptoms as well. And I will leave the neck findings to Robbie to layer on.
Yeah, thank you. Thank you. I mean, I think that's absolutely superb. Chronic cough may lead us nowhere, but in terms of a specific diagnosis, and it's hard not to take advantage of the fact that when chronic cough results in a non-specific diagnosis, it's usually without any accompanying clues. And so the fact that there's something else to digest makes it intriguing and increases the probability of a specific cause of that chronic cough. And so the question is, what do you do with erythematous papules? And the truth is that erythematous papules are highly nonspecific, and the pattern of which might be informative. So when you start with papule, you're like, the differential diagnosis is everything under the sun. What if they're around the neck? And so the neck location would make me think, are they around hair follicles? And this is actually just a case of severe folliculitis. Absent that, I would start to entertain, well, I would probably be using the neck location more than the nature of the rash itself, quite honestly, as I think this through now and say, like, is there an irritant exposure because of perfume or cologne or lotions, or like we alluded to earlier, hair and folliculitis. So isolated papules around the neck seem like the location has been determined by something specific, often something exogenous applied to the neck or folliculitis. But you can tell as I'm thinking in real life right now that my confidence around this analysis is weak, primarily because as an internist, you don't see dermatological problems beyond that initial first pass. So I'm challenging my mind to see if I know of any other associations that I would use as a backup, and I can't think of anything right now. So I would probably be leaning pretty heavily on excluding these exogenous causes and looking for folliculitis, but leaning more on being able to understand the visceral complaint cough better and be able to tie that in to a dermatological explanation. So that's probably how I'd be thinking about it in real time. And I will lean heavily on Gabrielle to give us much more information to make any light of this.
Yeah, I love that, RG. Like one other thing that I always think about, if like the rash doesn't have any symptoms associated with, people might just recognize that part of it. So like taking a look at the back, exam to just like make sure it might just be more generalized, and patient just hasn't noticed it because most often we can't see our backs, for example. So that might help us with our diagnostic journey going forward.
Love it. Such a good point.
Thank you, guys. Loving the discussions and the points on the chat. So for the second aliquot, the disease started 4 months before, and she referred productive cough and erythematous bumps around her neck. Over the course of the disease, the lesions grew up and appeared more lesions. Then she developed mild odynophagia and the cough has been persisting. She has received multiple treatments with multimycin, mupiromycin, fusidic acid, and also some antibiotics such as azithromycin, clindamycin, penicillin, and also betamethasone, but non-treatment did any effect of her lesions and the cough. So for the past medical history, she has diabetes mellitus type 2 and dyslipidemia. So she's taking metformin and atorvastatin. The family history is not remarkable. Social history, none. She does not smoke, doesn't drink alcohol. Health-related behaviors, she does not use any recreational drugs, and allergies, she doesn't refer any. In the physical exam, the patient generally looked well. In the pharynx exam, it was erythematous and mild congestive. In the neck exam, there were bilateral adenopathy, no painful at palpation, no painful at touch. And in the cardiovascular exam, it was normal. The pulmonary exam was normal. Abdominal exam was normal. Neuro exam also normal. And for the skin, I have a picture that I would like to show to give a better understanding how was her lesions. Thank you. So let me. So you can see here that there are erythematous papules around the neck that follows a linear pattern. And the patient refers that the lesion started like this, for example, like these little bumps. But then over the course of time, the lesions, these little bumps grow and transform into these bigger lesions and erythematous. There are they have a erythematous surface, and the papules are confluent. So yeah, that's basically the physical exam.
This is super, super helpful. It's amazing how the background data you provided and the additional information is so so informative. I have actually I owe a debt to somebody who I was talking with right before VMR, and that's Laura. She'd asked me, she's like, "You never shown me your dog," and I was like, "What?" I show my dog on every VMR, and this is proof, by the way. So this is Nar. I don't know if you can see him now. He's sleeping on the couch. Say hi, buddy. Say hi. He's very, very sleepy, as I told you. So now I've accomplished my task of showing Laura Nar. More importantly, that bought me time to think a little bit more. And I think what I will do is I will try to, it's hard not to immediately jump to reflecting on the exam. So I'll try to digest that and leave Charmaine to connect the dots with the background and the other HPI. So I think the exam is so illustrative of the key concept in dermatology, which is when you're trying to understand a rash, you need to know the width and the breadth. And the width is what Charmaine was talking about. She was saying, hey, Robbie, you know, just because the patient says that the neck hurts doesn't mean that there isn't disease elsewhere that she may not have noticed. And that's the width of the dermatological complaint. What body surface area, where does it belong? And there are sites where it may be not obvious to the patient, such as their back, or not obvious to the examiner, such as the axilla or the groin area. So take your time to understand, hey, do I have a good lay of land of the width of this rash? And the depth is really important too. In fact, when a red leg shows up in the emergency room and the red is really, the leg is really red, try to say that 3 times over. and the patient has a fever of 104, you better think it's neck fascia, and you better wonder how deep is it. And the question is, how deep is this process? And the finding of underlying cervical lymphadenopathy gives question whether this is simply the tip of the iceberg, meaning are these lymph nodes that are connecting to the skin and eroding into the skin. So the key question here for me, as we talked about earlier, which is let's understand the visceral nature of this disease process, then we understand the skin. Well, we might have to turn that question on its head and say, well, actually, there is no skin process. The skin process is merely the visceral process being so severe and so aggressive that it's literally poking a hole through the skin. And so I think the key question in this case is what's the lung stuff and what's the cervical lymphadenopathy? And I would use the rash maybe as a further clue, but probably merely as the lymphadenopathy poking a hole in the skin. So that's my analysis of the exam. I think for me, I would simplify this problem as a pulmonary disease process, as a potentially gastroesophageal disease process through dynaphasia, and then merge the skin into the cervical lymphadenopathy to simplify it. I'll pass the rest for Shami to analyze.
That was so beautiful. Reminded me of a Curbsiders episode when they were talking about the rash being like an outside job versus inside job. I really like that framing for me, novice dermatology enthusiast who's not very good at these things. It's just kind of simplifying that. I think like kind of to think about a background a little bit more. We started with the chronic cough and this erythematous papules around the neck, and then layered on like odonophagia. So I think like thinking about like multi-system disease process, as Robbie mentioned, that it's probably poking through the skin, and it involves what we know back of the throat and also like your GI tract in addition to the lungs, and kind of a background information. Especially the diabetes catches my eyes. To think the other thing to think about with the diabetes is just how severe complications of that diabetes is. Is it something that is well controlled? Being on metformin alone kind of alludes to the fact that it may not be as immunocompromising as possible. However, diabetes does put you at risk, of course, are infections, mucor being one of them. And the other thing to think about is like, skin plus lungs makes me think about like fungal infections too. The other thing to always like think about is like what the therapies we give for a disease. So this patient has received multiple antibiotics. The tempo of it and the lesion doesn't quite strike me as a drug reaction, but that's something to always consider. A lot more in medicine is iatrogenic that sometimes we care to admit. So I agree with RG is like kind of investigating the lungs to see what is going on there would be where I start. In addition to kind of think about the odonophagia a little bit more too, to see if that is like related or not. And I love Sammy's thought. Yes, absolutely. I would definitely do an HIV test on this patient.
Thank you, guys. So for the next aliquot, we have some basic labs. The labs were or normal. The hemoglobin was 12.9, platelets 222, leukocytes 7.66, and with a normal differential. The creatinine was 0.9, the glucose was 130, the liver enzymes were also normal. So basically just a normal exam. So we were wondering if this could be some etiology such as TB or fungi. So we asked for more workup, and we also performed a biopsy, some cultures of the throat. So for the chest X-ray, it was pretty normal, no alterations. The acid-fast bacilli stain of sputum was negative 3 times. The Y exam that evaluates exposure to tuberculosis was also negative. And the cultures for fungi and bacteria of the lesions around the neck were negative. And the pharynx culture grew up strep B, Streptococcus pyogenes. And what showed the biopsy? The biopsy showed an infiltrate of macrophages around that were forming basically granulomas. So it was a granulomatous tissue with inflammation. And the next aliquot will we asked more about the history, and she referred that 6 months before the lesion started, she traveled to the Peruvian highlands and also to the Peruvian jungle. And then the next aliquot will reveal the final diagnosis.
Oof, what a case. I'm so curious to hear RJ's thoughts, but I'm gonna just go through the data a little bit and then pass the mic to RG. So I think in general, like labs are informative because it tells you kind of the extent or the extent of the zero severity of it. The fact that all the labs are normal either means like, hey, we're just not seeing the effect of it in the labs at all, like it doesn't involve it, or it hasn't gotten severe enough to get to that point. And I think the ruling out TB always a great idea, like lower risk of active, at least pulmonary TB at this point. And then to kind of like think about the granulomas, never give up the opportunity to try to remember the schema for granulomas. I think like thinking about like the more common things like infection, autoimmune, and cancer. I think like whenever I try to think of granuloma, I'm like, the no misdiagnosis that I don't want to miss is a lymphoma. And then to think about infection, particularly just given the timeline of this disease, thinking about like kind of bacteria, Bartonella, in addition to like mycobacterial infections, I think about fungi like Candida and then mycoses. And I, before we were beginning this session, Robbie was just like saying, schistosomiasis. So schisto and leishmaniasis can do a thing as well. And then like autoimmune, not getting a flavor for this, but you know, a lot of our small muscle small vessel vascularity can do that, especially GPA. And thinking about like sarcoids as well. There are other rare causes like, you know, immune deficiencies, foreign bodies, and drugs that can do it. Allopurinol being the one that I think the most about, which patient doesn't have any exposure to it. I think with that, I'm still like the most worried about the infectious etiology given the time course. I'm curious to see what RG thinks.
Yeah, no, I completely agree with you. I think that like we're essentially revisiting our granuloma schema here, and infections are a leading cause. I think if you were to ask yourself, well, what passing thought should we give to non-infectious conditions after infections are included? And I think there's not much. Granulomatous in the neck, just to arm that list, is probably sarcoid, but I just want to arm you, since this is VMR, to think of a patient like this who has neck lymphadenopathy and lung disease, to think of a histiocytosis called Rosai-Dorfman. It's a diagnosis that we often miss, and it takes a while to diagnose, but certainly not the case here, especially given the epidemiological exposure. And I think I don't have anything to add apart from Charmine's analysis, but to anchor us in the basic principles of cervical lymphadenopathy. Most commonly, cervical lymphadenopathy of the infectious kind, you won't have an answer. It'll be a non-specific virus or a non-specific odontogenic infection causing local lymphadenopathy. So most times the infections are actually non-specific, but there are 4 categories of very specific infections. And 2 of them we're good at thinking about, 2 of them not so good. And the 2 of them that we think about quite frequently are Streptococcus. Of course, we have to think about group A strep when Uncle Bob or Bob Centaur is around VMR, but it's also a reminder that Non-group A streptococcal infections can also do it. And some of them are zoonotic. So strep, we usually think strep, meaning that it is a disease that the bug that we carry and that it takes over. But there are some strep species like strep suis, which we had a case of from Han in Vietnam. So there are zoonotic strep species that also can be in the throat that can go to the cervical lymph nodes. The other infection that we're pretty good at thinking about is mononucleosis infections causing cervical lymphadenopathy, HIV, EBV, and CMV. But the nature of the disease here doesn't really seem to fit, primarily because of the lung involvement. None of those viruses have prominent lung involvement. The third category is sexually transmitted infections. So syphilis, gonorrhea, and chlamydia. We just had a case of lymphogranuloma venereum, or LGV, on VMR causing lymphadenopathy. And the final category is the category that we have here, which is granulomatous lymphadenopathy. And the interesting thing about this case is if you apply the filter of what infections have a propensity to go, what infections that are granulomatous have a propensity to go to the lymph nodes. And there's 4 very common ones. There's TB, which Charmaine has mentioned, TB and NTM. Bartonella is a very, very big offender. Paracoxy is a big offender in its propensity for the cervical lymph nodes, and tularemia. So here, why is Bartonella less likely? One, Bartonella, again, is a disorder that spares the lungs. And here, the cough makes Bartonella less likely. TB and NTM are notorious causes, and just because we've had AFP doesn't mean they're off the table. But here, it's hard not to prioritize, I think, paracoxy because of the patient's epidemiological exposure and the cervical lymphadenopathy. But what makes paracoxy much less likely is this patient is a woman. The ratio of paracoxy in men to women of the chronic variety is about 10 to 1. There's something protective about estrogen, we believe, that causes paracoxy of this variety to be much less common in women. So we have many a good reason not to Bartonella less likely because of lungs. TB, you can never ever sleep without ruling out TB, but the AFP sputum make that less likely. Tularemia is a little bit less likely here because in the typhoidal form, which we would be invoking here, it's a little bit more hectic and a little bit more febrile, and the patient's not so well. And paracoxy is a little bit less likely because the patient is a woman. So the short answer is I don't know, and I think this case could turn into multiple different answers if you tweak a few things, or Gabrielle is going to teach us something that I've never heard about before. So either way, I'm really excited to learn, but I'm glad that the key thing was re-emphasized, which is the rash, the width and the depth helped us a lot. The width turned out to be that it's just the neck, and the depth turned out to be actually it's coming from the lymph nodes, unless there's a special clue that Gabrielle is going to share from us. So I'll pass the mic to Charmaine if she has any summarizing thoughts beyond what she was able to think about on the fly, and then hand it to Gabrielle to do some learning.
Just love listening to you reason, my friend. That is my reflection.
Yes, thank you guys. So for the final diagnosis, we were suspecting because in the physical exam we saw a linear pattern. It seems like it's like a sporothrix core pattern because it follows the lymphatic chain. So some diseases that can cause this are TB, and that could also explain the chronic cough. But the other differential that we also were thinking about could be if this could be cutaneous leishmaniasis, but at this point we didn't have a previous exposure. But then as we asked for a previous traveling, and the patient referred that 6 months before the lesion started, she traveled to the Peruvian highlands and jungle. Then we asked for more biopsies, and the biopsy showed a mastigotis positive for leishmania. So the final diagnosis was cutaneous leishmaniasis. Another differential that we were thinking was actinomyces, and also some deep mycosis such as sporothrix, as the names imply, a sporothrix pattern, and also sarcoidosis and some neoplasms such as lymphoma. So it was a very complicated case because the cough, the chronic cough, was very much noise in this final diagnosis. And in fact, we couldn't have like find a clear etiology for the chronic cough because leishmania doesn't explain that chronic cough. So for teaching points, for example, what we could have expect to see in the biopsy in a patient with leishmania is basically a lymphocytic infiltrate with granulomas. And some diseases that can also present like this pathology is TB and sporothrix Schenke. But what can make think about, for example, TB more if we see neutrophils, because finding neutrophils in the biopsy is not very much common in leishmania. And that's what I was learning in my dermopathology rotation. Yeah, so basically that's it. Hope you enjoy it.
Oh my gosh, absolutely superb. You know, I don't even know. I have a lot to reflect on this case, but I think it goes to show you that in the three fundamental arms of clinical reasoning, the first of which is what is the problem? The second is what is the answer? And the third is what's the solution? How do you fix it? If you don't know what the problem is, you can never get the right answer. And I think I'll speak for myself. All this time I was struggling with, I don't really know what the problem is. Is the problem a systemic disease that involves the lungs, the lymph nodes, and the skin? Or is it a disease that involves the lymph nodes and then rises to the skin? Or is it actually a disease of the skin that results in cervical lymphadenopathy as a reaction to it? And either those three problems are very, very, very different. And Gabrielle, before we hand the mic to Charmaine to reflect on Madalena, I'd love for you to teach us in retrospect how you might give us some advice on getting the right problem. What was the clue for you that it was a skin problem that resulted in lymphadenopathy as opposed to lymphadenopathy resulting in a skin problem? How would you have taught us to make that leap?
Yeah, the clue for me was the physical exam, the skin lesions that follow a linear pattern, and no many skin lesions present like this, and it was very important for me to separate the two things, maybe and so some guys also in the chat mentioned that this could be two separate diseases, so it's important to keep that in mind. And so for example, at the first, many of our team were like, this is TB because it can explain the chronic cough and the skin lesions, but keep in mind that this could be two different diseases process.
Beautiful. And I'll ask you one final question. Was the rash on both sides or was it on one side?
It was on one side.
That makes a lot of sense. I think now in retrospect, that the fact that it's just on one side and not bilateral is another interesting clue. I'm learning so much from this case. I should stop. I go forever. I'll pass the mic to Charmaine to share her reflection.
It's just amazing, Gabrielle. Incredible teaching, incredible case. And I couldn't agree with Robbie more. I think we all love reasoning, and at the end of it, the foundation of that still is medical knowledge. And if you have like a big gap, like in terms of like you're not recognizing the linear aspect, unilateral, like if that's just something you haven't learned, that limits you in a certain way to make correct diagnostic process, but not in real world. I know like I'm not very good at dermatology. So what I do is get help with dermatological issues. And I think a lot of the time with Gabrielle mentioned, like that skin biopsy is incredibly helpful. So as we gain more knowledge, just using our resources to make sure to frame the problem correctly. And one practice that I usually just try to impart on my team is just diagnostic pause, is that take a moment to pause even early on in a case and try to reframe differently if you can't make progress. I think especially when you're busy, especially when you have a lot of like cognitive load, it's so easy to anchor and to just let the diagnostic momentum get you through. And then just kind of reframing is like, hey, what if you take out the adrenophagia, that was like a strep infection, then how? What if the lungs are not actually an issue? Maybe it's chronic cough is separate. So just my favorite thing about diagnostic reasoning is like you have to keep asking why, and so keep asking why. This is so good. This kind of like covered all the things I love about diagnostic reasoning so well. So thank you, Gabrielle. I really appreciate you. And before we hand the mic to Madalena, RJ, do you want to plug tomorrow?
Hey, y'all. For those of you who have been part of this session since the beginning, we wanted to replug tomorrow since we're recording for people on YouTube who are primarily living on YouTube. We're very, very, very grateful to Maria and Sukriti for having the wisdom and the insight to put together a very special event tomorrow. The reason for that event is for us feeling more and more empowered and sharing our platform, which we're very lucky to build with all of you, to do good things in the world. And what we're hoping to do is to provide support to a group of people who are struggling and in a lot of trouble, and those are our friends in Ukraine. I just wanted to acknowledge that that is not the only place in the world that is suffering an extensive amount of devastation, and that the reason you're seeing the CP solvers rise to this specific occasion is a reflection of both our perception of what we can start to do. And I really hope that this is a beginning of many things of this nature, where we start to leverage the power of this community in VMR to do good in the world. And we're starting with Ukraine, but we won't end with Ukraine. And Ukraine is very important to us because the suffering of people across the world is exactly what we're gathered here today to try to minimize. The suffering medically, but also the suffering in the entire context of the world. So what's going to happen tomorrow? Well, you know, we're going to do our thing, except we're going to do it 4 times over. So I will put in the chat the link to the tweet that outlines this. But we're having 4 VMRs at 9 o'clock, at noon. These are all Pacific. 9, noon, 2, and 6. So 9, noon, 2 o'clock, and 6 o'clock. We're Pacific time. We're having VMRs with Reza and I, with Aaron, with Jack and Charmine, and Steph and Zavin, with outstanding case presenters also from the CP Solvers team. Gerline and Marie, Jack, and others are presenting too. I'm deviating from my script to not use names because I can't even begin to tell you who's been involved with this project. I know Lara has been leading the infographics team, and Madalena is here, but not to get too distracted on that. We really, really hope that you join us for a VMR extravaganza. And Ravi just put in the link, the most important part of this. We're really hoping that this will be a gathering of people on VMR to inspire us all to donate as much as we can to the effort. As Charmine said, Sukriti and Maria have created a event link to donate to Doctors Without Borders. The link is in the chat. We'll actually put the link under the video on YouTube so you all can see it there too. And we really hope to see you at any point tomorrow. If you can't make it, please consider donating regardless. If you can't donate, that is not a problem at all. You are a very valuable member of this community, and your mere presence, your donation of your time is more than enough for all of us. Anything to add, my friend Charmine?
That was beautifully said. And last but not least, good luck on everyone who is awaiting to hear where they're going to match tomorrow. We're thinking of you. No matter what happens, know that you have all the skills to be an incredible physician, and the program you have will be very, very lucky, and the patients that you get to take care of. All right, Madalena.
Okay, so yes, so excited for tomorrow, and I know it's been such a huge team effort making it happen, so very excited to attend. And also, Gabrielle, what an incredible case and wonderful kind of discussion. So I'll go through some teaching points. So when we got the chief concern of chronic cough and erythematous papules, for the cough part, we talked about really important questions we want to ask to kind of further characterize it. So for example, what is the duration of the chronic cough? What other symptoms are present, for example, weight loss? And we want to think of the differential for common causes of chronic cough, including GERD, postnasal drip, and asthma. And then we know that, of course, the workup would involve a chest X-ray at some point. And then when we move to erythematous papules, we talked about how that's a pretty non-specific sign. But when we look at the location, we want to think about things like an external irritant exposure, potentially folliculitis because it's around hair follicles. But the really important point that just because the patient mentions a rash around the neck doesn't mean that it's not present in any other locations. We want to make sure we do a complete exam to see the full extent of the rash. Then when we got some more background information and saw that the patient had diabetes, it's really important to think about how well controlled the diabetes is, because that disease, it really increases the risk for specific infections like mucor. Then when we got to the exam, so for rash, we talked about how important it is to look at the width, the breadth, the depth, and also if it's unilateral or bilateral, because that will help us frame kind of the right problem, if this is a skin problem leading to lymphadenopathy, or if it's the lymphadenopathy leading to the skin problem. And Charmaine mentioned this really interesting framing of the rash. So is it an outside or an inside job? Then when we are able to combine the skin and lungs being kind of the dominant manifestation of the disease, we want to consider infections or drug reactions. So for granulomatous processes specifically, we can think of the big buckets of infection, autoimmune. So infections, we want to think of Bartonella, Candida, Leishmania, and also histiocytosis. Autoimmune, we can think of vasculitis and sarcoid. And lastly, we talked about the 4 categories for specific infections that can cause cervical lymphadenopathy. So we talked about streptococcus, like group A strep, even zoonotic infections, mononucleosis, like HIV, EBV, sexually transmitted infections, and then lastly, granulomatous infections. And finally, Gabrielle gave us a really helpful teaching pearl that for Leishmania, what you would see on biopsy would be a lymphocytic infiltrate with granulomas. And the differential there could include TB and Sporotrix. So thank you, everyone. What a fantastic case.
Thank you all. That was awesome, Madeline. I really appreciate you. Hope to see you tomorrow all. Thanks so much. Bye.